Hello, everybody. Welcome to November's CBC conference. I will be moderating things on the back end here. So if you have any questions or if something isn't showing out right, just give me a little ping. Please make sure that you are getting your CME credits by logging into the CME portal after this. We have APA. I will be sending along the Qualtrics evaluation partway through this event. Please fill out the evaluation form. I'll also be sending it via email afterwards if you aren't able to copy that down. And please be sure to mute yourself as you come in. If you're not muted already, please do so, just so we don't have a bunch of noise in the background. And I think we're going to just roll right into it. Roger will be presenting the clinical history first.
Okay, all right, let's get started. Can everybody hear me okay?
Yes.
All right, okay, let's go to, so this was all right, the subject today is a 69-year-old man initial evaluation who was initially seen in the fall of 2016 by Andy Ritter and Judy Heidebrink in our clinic, and he was referred, of course, for evaluation of cognitive decline. Notable point, I think, is this is a very well-educated individual. He had a master's level education and worked actually as an auditor for a variety of companies. His history is provided both by him and a family member who accompanied the clinic. And he reported a 6-month history of difficulties with memory function, some problems finding words, and problems, doing computer-based tasks with which he was, previously quite facile. Looking farther back in his history, apparently abruptly retired from working in February of it should be 2016, not 2019. Maybe I have the wrong, one of these dates is wrong. Anyway, he abruptly retired several months earlier. He denied major work-related problems, but did describe problems recalling people's names. The family member who accompanied him described a longer period of some decline in cognition and also described problems with memory function, some difficulty with finding the right word to say. He was also described as being more withdrawn and less talkative. And family member described him as slower, but did not describe any clear-cut specific motor dysfunction features. There was no history of any hallucinations or cognitive fluctuations. His wife had become more involved in managing his finances, but he continued to manage his own medications. And he had had 2 minor motor vehicle accidents, one of which was related to becoming lost in a situation where he should have been familiar environment. His past medical history is notable for history of hypertension, hyperlipidemia, coronary artery disease, treated hypothyroidism. He'd apparently had a 70-pound weight loss in the couple of years preceding his evaluation. And medications were non-contributory. There was a family history of dementia and his mother, who apparently had onset of dementia late in life. And on examination, his general exam was unremarkable. His neurologic exam was unremarkable. His score on the Montreal Cognitive Assessment was 18 out of 30. He had problems drawing the cube, problems with naming, attention, and with recall. And he had MRI imaging, which showed diffuse moderate atrophy, but was otherwise unremarkable. And the diagnostic impression was that he had a dementing disorder. Next slide, please. Okay. So he had an initial evaluation, follow-up evaluation shortly after his initial evaluation. This was after neuropsychology, which will be discussed shortly. But the clinical impression at that time was probable Alzheimer's disease. Donepezil was started, and it was recommended that he stop driving. And he was followed up about every 6 months until 2019 by our now retired excellent APP, Chris Tomasek, who documented in her notes a gradual decline in memory and language functions over subsequent years. Gradual decline in independent activities of daily living. There were relatively few behavioral problems. There was some manageable irritability. One of the notes mentions that he used to go out walking a great deal to keep himself occupied during the day, and his family would rig him out with a safety vest and actually a tracking device to keep track of him, because he would just go out walking for miles and miles. As part of his participation in the Alzheimer's Center, he had a couple of UDS evaluations. One was in the winter of 2018. At that time, his CDR sum of the boxes score was 4. His neuropsychiatric inventory was positive for mild illusions and possible hallucinations. He had multiple impairments on the functional assessment battery, and his MoCA score at that time was 14 out of 30. He had an unremarkable neurologic exam, and his diagnosis was felt to be Alzheimer's disease. He was seen back about a year later. At this time, his CDR sum of the boxes score had risen to 6.5. This was because of increased scores on the behavioral component. Correlating with that, his NPI documented worsening agitation, aggression, and irritability. And again, he continued to have multiple impairments on the frontal assessment score, and his diagnosis was continued as AD. Next slide, please. Now, he had a couple of interesting follow-up evaluations. In January of 2019, he reported some visual problems, and he was seen in the ophthalmology clinic. And he had a routine evaluation which revealed the evidence of a right homonymous hemianopsia. And yet subsequent evaluation for the hemianopsia, and it was felt to have optic apraxia, simultagnosia, and optic ataxia, so-called components of the so-called Balint syndrome. He had a follow-up MRI, which had evidence of more diffuse atrophy, but no evidence of a specific visual cortical abnormality. Later in the fall of 2019, he was placed in an extended care facility. In the fall of 2020, we were not seeing him at this point in the clinic because of difficulties in transportation, but the family notified us that he was in hospice care, and then in November of 2020, he died, and his brain was extracted for study. Next slide. So briefly, for those of you who aren't familiar with this, Balint syndrome is syndrome of really a posterior cortical syndrome, and it's characterized by 3 features. So optic ataxia, ocular motor apraxia, and simultaneous nausea. And optic ataxia is the inability to guide your hand or arm movements under visual guidance. In contrast to doing something with tactile guidance or something along those lines, these are people who they don't seem to be able to use their vision in order to guide their manual function. Ocular motor apraxia is usually an impairment of voluntary saccadic eye movements, where people have difficulty voluntarily moving their eyes from one target to another. And simultaneous nausea is the inability to sort of visualize or perceive more than one object at a time. So think of this as having no forest for the trees type of thing. You can only see a single tree as opposed to seeing multiple trees of the forest. And it's associated with posterior cortical pathologies. It's not, specific to any individual type of pathology, but certainly is seen in some degenerative disorders, particularly things like posterior cortical atrophy can manifest Balint syndrome. Next slide. Okay. So weight loss, a premonitory feature of, so some questions now. Weight loss a premonitory feature of AD? So please answer the question and submit. Okay, Stephanie, you'll have to tell us when we get the answers back. So.
Yep, I'll give it just a couple more seconds. Most people have answered.
No rush. Okay, so most people like me equivocate, maybe. And I think that's a fair answer. There is some literature, some of which comes from some very good centers looking at AD patients and documenting significant weight loss in the years leading up to diagnosis. Now, I don't think this has been a universally reproduced findings, though it has been reported by some very good groups. But certainly, a 70-pound weight loss is sort of eye-catching, and usually in conventional terms makes you think about other things like a malignancy or something like that. But I think the truth is, I think this can be a premonitory feature of AD, and I wouldn't immediately assume that in a situation like this, but it's worth considering. Okay, how about question number 2? How common are visual field deficits in Berlin syndrome in typical AD? Okay. Okay, so the winner here is uncommon, and some people go for unknown. I think the correct answer actually is unknown. It's very hard to know. So it could be, certainly this is the kind of thing you would see in posterior cortical atrophy, which is, usually has underlying AD pathology. But there have been a couple of reports of people who develop with more typical dementing disorders, Alzheimer's courses, who develop these kind of features. On the other hand, this is something that's very, very difficult to study because in order to really establish the presence of these kind of deficits, you actually need to have patients who can cooperate with you in a fairly detailed examination. So the way, for example, this individual is diagnosed as having a visual field defect was on the Humphrey perimetry apparatus, but that requires the patient to give an accurate response to this presented stimuli. So if there are difficulties with cognition, those could clearly confound this type of thing. Having said that, it's quite plausible that people with typical AD could develop these type of features, but our ability, I think, to characterize them in patients with more advanced dementias is very, very limited, I think. So I would say it's unknown. Okay, last question, is this a rapid course? Okay, so the winner here is yes, and I would agree with that. So as best we can tell, this gentleman went from probably some of his initial manifestations, at least taking his family's history of cognitive impairment to being deceased within less than 10 years. And in addition to that, now we don't have a lot of information about what happened in the last couple of years of his clinical course, so we don't know if there was a confounding superimposed medical problem, which of course is common in older people. But in general, I would say this is a relatively rapid decline in course for this individual. I think one point I think that's worth commenting on is that he was a relatively well-educated man who clearly functioned at a high occupational level for most of his life. And I think, as most people here know, there's a substantial literature indicating that education has some protective effect in terms of later life cognitive impairments, and that there is, again, some data that suggests that higher levels of education seem to actually protect people from having the impacts of age-related pathologies, even when efforts are made to try and control for the density of those type of pathologies. But some of that same literature also suggests, in fact, that when well-educated people who presumably have this cognitive reserve that can protect them somewhat, when they actually start to decline, they decline at a faster rate. So, so I think education is good in the sense that it's clearly, I think it's now very well documented in the sense that it's protective. There is this other component where there is literature suggesting that these individuals who have the protection also have a faster rate of decline when symptomatic. That's consistent with the overall concept of cognitive reserve, which has been developed by Jakob Stern and his colleagues. And And the idea being there, you have these compensatory mechanisms, but when your compensatory mechanism starts to fail, you're going to fall faster. So any comments from the audience on these points? Okay, I think we can go on to next component.
All right, so I'll be presenting the neuropsych data for this patient. He completed a full neuropsychological evaluation in 2016 and then a UDS battery in 2018. By 2019, he was too impaired to complete any neuropsychological testing. So we've kind of gone through the background. So he was 69 at his first encounter. He's married. He had 2 master's degrees. In his neuropsychological appointment, he reported that his retiring was because of his symptoms. And he'd had symptoms for about 18 months. He was having difficulty with recall of recent events, conversations, names, word finding, and he reported slow information processing. So in 2016, he was mostly independent in his basic ADLs. He'd had some decline in IADLs. His wife had taken over financial responsibilities and was providing oversight in medication management. He was still driving, but he'd had these 2 car accidents. He wasn't having any problems with sleep or energy at this time. He was walking about 3 to 5 miles a day and eating a vegan diet and doing some travel. He had no history of any psychiatric diagnoses, but his family reported that he'd been quieter and more withdrawn in the past 6 months. He noted himself that he was feeling less confident in conversations. And he reported that he might have had a hallucination at a party, but he wasn't sure if it was a hallucination or a case of mistaken identity. So by 2018, he was still reporting some possible hallucinations, some mild agitation and irritability, but still no depression symptoms. He was no longer driving, and he had declined in his IADLs. In 2019, he was no longer reporting hallucinations, but they were reporting delusions. He had some continued aggression, irritability, anxiety, disinhibited, and an increase in appetite. So he had, by this time, was fully dependent on others for IADLs, but he was doing some housework with support and needed prompting for ADLs. So behaviorally, in 2016, it was noted that he spoke with frequent halting and long response latencies. He needed encouragement on memory tasks, and he had difficulty comprehending instructions across tasks. For example, he couldn't understand the instructions for Trails B and discontinued. In 2018, it was noted that he was having some pretty significant visual spatial processing impairments. There was a mild action tremor noted. He was losing his train of thoughts. He was impulsive. And then on Trails B, he again was having problems. He couldn't find the B within 3 minutes. So got a lot of information just kind of on his background. I'll present the scores from his testing at these time points. Just kind of wondering what people are thinking right now, sort of your top choices for your diagnostic considerations. All right, do we have results for the poll yet? Okay. All right, so it looks like a lot of people are thinking Alzheimer's, PCA, and Lewy body. A little bit of thought for vascular dementia. Okay, so his specific scores on testing. So he did a number of different screening measures. So just kind of the Total scores. So in 2016, in April on the MMSE, he scored a 27. He lost all the points on delayed recall. His MOCA in 2016 was 18 out of 30. September, he did another MMSE, which was down to a 23 out of 30. In 2018, his MOCA was down to a 14. And then here's kind of the breakdown of his MOCA scores. They have the specifics on the MOCA. So you can see he's by 2019 or 2018, after 2 years, he's losing more points on executive functioning and visual spatial, attention, and orientation. He's floor on memory across. And then by 2019, he's so severely impaired, he can't participate in MOCA. So just some examples of his drawing. So here is his clock in 2016. This clock was 10 past 11. So he's incorrect on the time. He's close. You can see kind of some planning errors in making his clock arms. Looks like he tried to maybe move his 11 over. I don't know if that was an extra 1 or he's just trying to move the 11 over. And then by 2018, this is a considerably smaller drawing. It's a smaller spot, so it's a little harder to fill all the numbers in, but it's pretty disorganized. He doesn't have the time and can't get the numbers in the circle. So at his 2016 neuropsych evaluation, so we have here the normal curve, which I'm sure everyone on this call is familiar with. His premorbid estimate was average, although note it was really right at the low end of average. So he did have 2 master's degrees. So this is kind of interesting. Maybe reading wasn't his strength, or maybe he was already having some visual problems by this point and not able to kind of see all the words clearly. I'm not sure. His phonemic fluency was average. He was able to do a simple copy drawing. Tapping on his dominance, his right hand dominant, was average. He was kind of starting to have some difficulty on working memory tasks, but it was split. He had more difficulty on the arithmetic task. His non-dominant tapping was lower so his left hand was slower. He was having some difficulties with naming at this point. Executive functioning was overall below expectations, but it was kind of split. He was able to, on the card sorting task, get 2 categories, but he made a number of different errors and he was somewhat perseverative on the task. But again, he was unable to do Trails B. And then he was impaired in a lot of areas at this time. So processing speed, sustained attention, verbal and visual memory were pretty close to the floor, semantic fluency, and visual, spatial, and perceptual abilities. So then moving to 2018. So his performance on naming increased. So it was not the same test, but he was able to perform in the average range in 2018. His premorbid was lower in 2018. It was a different reading task, but I'll just note in 2018, it was kind of on the higher end of low average, was on the low end of average. In 2016, so it wasn't a huge drop. It just was enough to drop him down the norms. He was slightly improved on a semantic fluency task. His working memory was still was split between being, very impaired and slightly impaired, but he had gone down on these measures overall. Processing speed continued to be impaired. Sustained attention was impaired. Executive functioning was more impaired at this point, just totally floor on the tasks. Verbal and visual memory were again at floor, and phonemic fluency performance was lower. Visual spatial skills were very impaired. So with that new testing information, does that change anybody's considerations for diagnosis? I'll just do the same poll again before we go into getting the pathology. Okay, so pretty close. A few more people are feeling Lewy body, but otherwise we're in the same ballpark. All right, so that's all I had for the neuropsych. Does anyone have any questions before we move on? All right.
All right, hi everyone. I'll be talking about the neuropathology findings for this patient. Hopefully you all can see my slides. So just starting with the gross examination. So the whole brain weight in this case was 1,450 grams, which is well within the range of normal. And actually there was not terribly notable atrophy, at least on external examination. I think it's kind of difficult in areas where the brain is covered with meninges, but if you look at these kind of small areas where meninges have been stripped, you can see that the gyri are pretty closely packed. Sulci are not too prominent. So at least externally, not a ton of atrophy. However, once we cut cross sections, it starts to look a little bit different. So here you're at the level of the globus pallidus and the mammillary bodies, a little bit of thalamus and the mammillothalamic tract right there. So here, if you look at the ventricles, you can see, you expect them to be kind of like slit-like with this fairly acute angle here. And you can see it's like this pretty wide U angle. So suggestive of like mild to moderate dilation of the lateral ventricles. And then a little bit further, here's a section at the level of the hippocampus with the lateral geniculate. Again, some thalamus here. And you can see that this tip of the lateral ventricle is extremely dilated. Like here, this should be really a slit-like space with the hippocampus hugging pretty closely, and instead it's quite dilated. However, the hippocampus itself doesn't look terribly atrophic. We always use the benchmark of like about the size of a like the eraser on a pencil. This was about right. So now moving on to the microscopic evaluation. This is kind of a medium power view of the frontal cortex. So you can see, I think you could appreciate there's some mild vacuolation of the neuropil, kind of got these little white spaces up here and around neurons. We also have a little bit of gliosis, and then we also have kind of these pink speckles in the neuropil. And if you take a closer look at these, so the neuropil should be this kind of fine granular consistency throughout. And you can see right here, you have a disruption of this consistency. You have these kind of like fibrillar and these like chunky, coarse granular things. And if you look at this same area with the beta amyloid stain, you can see a really nice example of a neuritic plaque. You can also see that there are several diffuse plaques around those. Those are quite a bit more difficult to identify on H&E. And now if we take a low power view of the same section, again, frontal cortex with beta amyloid staining, you can see there's quite a bit of amyloid pathology here, quite a few neuritic plaques, tons and tons of diffuse plaques, and then a little bit of vascular pathology. So as I'm sure most of you are aware, amyloid pathology and tau pathology can be seen in this kind of wide spectrum of clinical phenotypes ranging from like no dementia, kind of normal aging versus very severe Alzheimer's disease dementia. And so the way we kind of handle these cases as pathologists is that we give this tripartite score, this ABC score, where we score the distribution of amyloid pathology, the distribution of tau pathology, and then kind of the density of amyloid pathology. Based on these three scores, we come up with either this is not Alzheimer's disease neuropathologic change, or there's a low, intermediate, or high likelihood that these changes would be associated with clinical dementia. So moving on to assessing this patient. So to assess first the A, which is the thal phase or the amyloid distribution. So amyloid pathology progresses in this kind of stereotyped fashion in ADNC, where we first have neocortical pathology, then we start to get pathology in kind of the deep gray structures, the brainstem, and then eventually the cerebellum. So we sample all of these areas fairly extensively and then do screening amyloid stains. And just to kind of go for some of the kind of higher stage areas. So here what you're looking at is section, here's the base of the brain down here. This is thalamus. This is this lens-shaped nucleus right here is the subthalamic, and then there's a little bit of the substantia nigra. And then just to show you, this is kind of normal population of pigmented neurons in the substantia nigra. And then if we look at the beta amyloid stain, you can see a couple areas here where you have pigment that's kind of a different shade of brown, and it's not this kind of finely granular distribution. So these are amyloid plaques that are within the substantia nigra. So kind of high, like amyloid pathology moving beyond the neocortex. And then this is a kind of low power image of the cerebellum. Here's the cerebellar granular neurons here. There's the Purkinje cell layer. And then here at low power, you can see what look like amyloid plaques. And then there they are at higher power. So when you assess this case, you find amyloid pathology has spread basically all the way into the cerebellum. So we're now in phase 5 or A3. So now we stage the tau pathology. The most critical section in staging tau pathology is the hippocampus. This is just a little diagram of kind of the microanatomy of the hippocampus. You have the dentate with CA4 in the center, spooling out to 3, 2, 1, and then the subiculum, the presubiculum, entorhinal cortex. And tau pathology also progresses in this kind of stereotyped fashion, beginning in the transentorhinal and entorhinal cortex. Those are Brock stages 1 and 2. They're called the transentorhinal stages, as you would expect. Then it starts to progress. More dense pathology in the entorhinal cortex starts to involve the hippocampal formation. These stage 3 and 4 are referred to as the limbic stages. And then it starts to involve more densely other cortical areas, especially like the temporal cortex. And so stage 5 and 6 are called the neocortical stages. So just doing some picture matching, here's a low power view of the hippocampus for this patient. So you can see, I'm not sure if this was understained or what exactly is happening. It's a little bit underwhelming. Like usually it's kind of a more dark brown, and here it's like the color of, I don't know, like weak tea. But you do see tau pathology within the hippocampal formation, obviously in the entorhinal cortex, sparing the subiculum as you expect. And then you see quite a bit of pathology within the temporal isocortex. And just going higher power to further appreciate. So you can see that quite a bit of the pathology, the tau pathology is actually due to tau deposition within neuritic plaques. So that you can just kind of tell by the morphology. The plaques look like, I don't know, like kind of like globules and dots that are all like kind of smushed together, as opposed to the neurofibrillary tangles where you have kind of clear fibrillar staining around the nucleus. And then you also see this dense network of tau neurites all around. So true dense tau pathology in the temporal cortex. So now we're definitely in the cortical stages. One area that's extremely helpful to evaluate to kind of separate out stage 5 and stage 6, in which you'd both expect kind of dense pathology in the temporal isocortex, is actually the primary visual cortex. So so tau pathology in stage 5 kind of densely involves the temporal isocortex, partially involves the occipital cortex, but spares the primary visual cortex, as opposed to stage 6. So we always take a screening section of the primary visual cortex, which is what you see over here on the left. And you can see, again, dense tau pathology. You can also see it nicely highlighting the line of Gennari right there. And then if we go a little bit higher power, again, we do see these neuritic plaques, but we also see true neurofibrillary tangles and tau neurites. So this easily qualifies as Brock stage 6 or B3. All right, and then finally, kind of the last piece of scoring criteria is the CRAD score, which is the density of amyloid pathology. So here you just kind of look at all your cortical amyloid sections and you look at where amyloid pathology is the most dense. And then again, you use this kind of semi-quantitative scale. Are there no neuritic plaques versus very dense neuritic plaques? And this was thought to best represent like dense neuritic plaques, so C3. So unsurprisingly, if you're the highest in every category, you have a pretty high likelihood that this would lead to clinical dementia. All right, and so then I'll just kind of breeze through the rest of the pathology. So I'll just mention, I didn't realize Lewy body pathology was really in the clinical differential, or I would have shown some images, but there is no, we also do screening stains for alpha-synuclein in the anterior cingulate and the substantia nigra. There were no synuclein inclusions. There was nothing that looked like Lewy bodies on H&E. So no suggestion of Lewy body dementia. So moving on to the vascular pathology, these are some kind of superficial cortical and leptomeningeal vessels that are overlying the frontal cortex. You can probably appreciate that these vessels are too thick, and then there's some hemosiderin deposition. Other areas, again, still overlying the frontal cortex, you can maybe appreciate that the vessel is expanded with what we always refer to as like this bubblegum pink amorphous material. And if you put a beta amyloid stain on that, it lights right up. So this patient also has cerebral amyloid angiopathy. And then finally, this is the middle cerebral artery. If you look over at kind of these areas over here, you can see nicely the 3 layers, the intima, internal elastic lamina, media, and adventitia. And then if you look over here, you can see the intima has been expanded with this kind of calcified plaque. In other areas of the middle cerebral artery, you can see these really classic cholesterol clefts. So these are like the classic findings of atherosclerosis. So this patient also had atherosclerosis. So one point from kind of a pathology perspective is I thought there was a bit of an interesting disconnect in the degree of atrophy we saw versus the degree of tau pathology. So as I'm sure all of you know, atrophy is characteristic of AD. We often see like the thinning cortex, the enlarged ventricles, and then in particular loss of like hippocampal volume. And over here on the right is just, these were like 80 patients that all went to autopsy and had at least 2 volumetric MRI scans. And you can see that the change in brain volume per year in some neurodegenerative diseases like Lewy body dementia, really not significantly different from normal aging, but other diseases like Alzheimer's disease, pretty stark difference, stark increase in atrophy, as I'm sure, as we've also seen, you know, anecdotally. Interestingly, in this study, which looked at 50 patients that all had ADNC with Brock stages varying from 3 to 6, they found that really the defining pathologic change that predicted atrophy is tau pathology rather than amyloid pathology. And in fact, you actually don't start to see true atrophy on MRI, at least significant atrophy, until you start to get to these later Brock stages. And this was postulated to be because the density of tau pathology varies so much in these earlier Brock stages as opposed to the late Brock stages. So in terms of why in this patient, there was a bit of an disconnect between sort of the degree of atrophy we saw grossly and the degree of tau pathology we saw microscopically. I thought it actually might be because the degree of tau pathology the density of tau pathology didn't really appear to match up with the distribution as much. So with the distribution in the occipital cortex, it's Brock stage 6, no question. But usually you do see quite a bit more density in terms of more density of neurofibrillary tangles, more density of tau neurites. And I also wonder if kind of the density of tau pathology in the occipital cortex, as opposed to, in contrast to the relative paucity in maybe frontal and temporal, could help to explain like this clinical presentation with these sort of prominent visual symptoms. All right, so that's all I have for the neuropathologic findings. So happy to answer questions or to open it up for discussion.
Do we have any questions or comments for our speakers? We have quite a bit of time for any discussion we might want to have.
Let me just comment. So Emily, I think this is really typical AD. This wouldn't be what you would typically see in the posterior cortical atrophy, however, correct?
So from what I've read, posterior cortical atrophy is like a clinical diagnosis that kind of breaks down where some people end up neuropathologically having AD, some have Lewy body disease. So there have been studies looking at patients with neuropathologic AD that have like this posterior cortical atrophy kind of presentation, and it's sort of a mixed bag. Some studies have seen like there's more pathology in the occipital lobe compared to the frontal lobe, if you look at those patients in comparison to like the traditional AD presentation. Other studies have not really seen that.
I think it is usually, I mean, it is usually AD in most studies, AD pathology in most studies, but yeah, but okay, that was helpful. Thank you.
That's at least what I read.
Anything else? Any other questions? I can't possibly believe we would end early. That's crazy. Now, I thought this was a very interesting case. Looking at the cognitive reserve is always impressive and makes me think, gosh, what did his brain look like before he saw any sort of changes?
Yeah.
Oh, it's
Interesting. Yeah. All right.
all right. Well, please be sure to fill out the Qualtrics evaluation. I posted the link in the chat, and if we don't have anything else, I think we'll be finishing up early. Oh, I think we had something. I have any brain images for this case?
No, the short answer is no. I think I looked at his, he had MR imaging at the early in his evaluation, and I looked at the studies, and they were pretty unimpressive. So no.
All right. Well, thank you so much for coming out today, and make sure that you get that CME credit if you would like. So I will stop recording now and have a wonderful rest of your day.